All right, so we are picking back up here on chapter 9, joints. And now we'll be talking about our synovial joints and the types of movements that you can see at these synovial joints. So this first slide here is simply an outline or a listing of the types of movements that we can see. And next we'll talk through with some images and showing you some descriptions of these movements and what's happening. So the first is going to be a gliding movement. This gliding movement will occur when we have relatively flat bones, as you see here. When they move back and forth and from side to side with respect to one another. In our gliding joints, we have no significant alteration of the angle between the bones. So there's no significant change of the angle between the bones. They just glide or slide along one another. And gliding movements will occur at our plantar joints. And then we have our angular movements. In angular movements, there's an increase or decrease in the angle between the articulating bones. And so that's how they got their name, angular. We have some principal angular movements that are flexion, extension, and hyperextension. See those here? Flexion, extension, and then the hyperextension as well as here, here, here. And then we also have a lateral flexion movement. So flexion will result as a decrease in our angle between the articulating bones. So see here, we have a decrease in the angle. And then extension results then as an increase in the angle in our articulating bones. When we have the lateral flexion, that's going to involve the movement of our trunk or our torso here sideways. So to the right or to the left at your waist. This movement occurs at your frontal plane and will involve your intervertebral joints. And then now hyperextension. Hyperextension is when we continue the extension beyond the anatomical position. And normally hyperextension will be prevented by the arrangement of ligaments and the anatomical alignment of bones in our body. Our other angular movements are abduction and adduction, and then circumduction. So abduction refers to the movement of the bone away from your midline, so abduction, and adduction refers to the movement of the bone towards the midline. I had someone in a class tell me once that abduction is away. If someone is abducted, then they are taken away from what they know or their family. So abduction will always be to move away from the midline or away from your body or the other parts of your body here. The fingers are moving out away from one another. And adduction, you have to add something together, and so you bring it to your midline or to your body or together. Now, circumduction here will refer to a movement of the distal end of your body, and it moves in a circle. Circumduction occurs as a result of a continuous sequence of flexion, abduction, extension, and adduction. So 4 continuous things: flexion, abduction, extension, and adduction. Condyloid, saddle, and ball and socket joints will allow for circumduction. We'll talk about those types of joints in just a second. And next we have rotation. In rotation, the bone will revolve around its own longitudinal axis. So here, the head is moving from side to side, so this is rotation at the atlantoaxial joints. Our rotation It will be in pivot and ball and socket joints. If the anterior surface of the bone of the limb is turned towards the midline, then we call that medial rotation. If the anterior surface of the bone of the limb is turned away from the midline, we call that lateral rotation. So we just use our directional terms to describe this location. We also have a few special movements of our synovial joints. We have elevation, which is going to be an upward movement of your body part, and depression is the opposite, a downward movement of the body part. Protraction is a movement of the body part anteriorly in the transverse plane, whereas retraction is when we protract part back to the anatomical position. So after protraction, retraction occurs to place us back in anatomical position. We also have inversion and eversion. In inversion, the movement of the soles of the feet move medially at the intertarsal joints so that they face away from one another. And then in eversion, we move the soles laterally at the intertarsal joints so that they face away from each other. So inversion, the soles of the feet will face in towards each other. Eversion, the soles of the feet will face away from one another. And then we have our dorsiflexion and our plantar flexion. In dorsiflexion, we bend the foot at the ankle in the direction of the superior surface. And in plantar flexion, we bend the foot at the ankle in the direction of the plantar surface here. And then we talk and move to our palms or our forearms. And we have supination and pronation. Supination here will turn our palm anteriorly. It involves movement of the forearm at the proximal and distal radial ulnar joints, and the palm will turn anterior and superior. Pronation will be the opposite, movement of the forearm at the proximal and distal radial ulnar joints, in which the distal end of the radius crosses over the distal end of the ulna, and then the palm is turned posteriorly and inferiorly. And then finally, opposition involves movement in the thumb at the carpo-metacarpal joint, in which the thumb moves across the palm to touch the tips of the finger on the same hand. We have a summary of all of these movements here in this following couple of parts of the table that are broken from your book. Now, let's talk about our types of joints here, of synovial joints. So we're still talking about the synovial joints. Our first synovial joint that we'll talk about is a plane joint. This plane joint also can be called a planar joint, and its goal is to permit movement mainly in a side-to-side fashion and a back and forth. So remember, we talked about the gliding movement, and we said that it was the plane joints that would do that. So these joints will be non-axial and include the intercarpal, intertarsal, sternoclavicular, acromioclavicular, sternocostal, and vertebrocostal joints. And so these will allow movement along 2 or 3 axials. So it is biaxial or triaxial. Next is our hinge joint. Hinge is probably one of the most common joints we think of when we think about the joints in our body. And our hinge joint contains a convex surface of bone here. So where the ulna is here is this convex surface. And it will fit, this is the concave surface. So it contains this convex surface here, the humerus. And this convex surface of one bone fits into the concave surface of the ulna here. And the movement will primarily be flexion and extension in a single plane of movement, giving us this uniaxial joint. So, of course, we've shown the elbow here. Your knee, ankle, and interphalangeal joints are also examples of a hinge joint. And then we have our pivot joint. At the pivot joint, we have a round or a pointed surface of one bone fitting into a ring formed by another bone and a ligament. And then movement will then be rotational in a uniaxial or monoaxial direction. And so an example would be your atlas rotating around about the axis, or our radial ulnar joint as shown here. Our next type of joint is going to be the condyloid joint. So condyloid synovial joint. The condyloid joint is going to be an oval-shaped condyle of bones fitting into an elliptical cavity of another bone. So oval shape fitting into the elliptical cavity. And the movement here will be flexion and extension, abduction and adduction, and there is some limited circumduction that can occur as well. So here we have the example between your carpals and your radius. And so this is how your wrist is able to bend. Your wrist is able to kind of circumduct, creating that round movement in a circle. And then we also have our saddle joint. The saddle joint has a bone whose articular surface will be saddle shaped, and then another bone whose articular surface will fit like a rider sitting in the saddle. So here we have our saddle joint. And so the movements will be flexion, extension, abduction, adduction, and also circumduction. And so example here would be between the trapezium of the carpus and the metacarpal of your thumb. So this joint here is a saddle joint. We have one portion like the saddle and then a rider or something fitting into that joint. And our last type of synovial joint here is another commonly thought about joint. It's the ball and socket joint. So in the ball and socket joint, the ball-shaped surface of one bone fits into the cup-like depression of another. And we are able to create the movements of flexion, extension, abduction, adduction, and then rotation and circumduction. So the only places we do find this, though, in the body will be your shoulder joint and your hip joint as shown here. So here is a nice summary and review of the types of synovial joints, the classifications of them as well. So you'll want to know what makes up that type of joint, and then make sure you know the functional classification. So in how many directions or how many planes do we allow movement, and what types of movement do we allow as well. There are certain factors that will affect whether our joints contact each other, as well as the range of movement we'll have at those synovial joints. And so these factors would be, of course, the structure and the shape of the two bones that are articulating, or the number of bones articulating. It'll also be the strength and the tautness of the joint ligaments. So the stronger and the more taut the ligament, the less range of motion we will have at those joints, but we will have a nice tight contact point. And then our arrangement and tension of the muscles. We know that if we are very tight and have not stretched, or for some reason we're just tight in general, that it is harder for us to have a wider range of movement. And then the contact of the soft parts will also affect the range of movement. We also have hormones that will affect our contact and range of motion at our synovial joints. And then finally, the last thing that's going to affect the range of motion is disuse. So if you have ever broken a bone or know someone who has broken a bone and then they've been in a cast before and they haven't been able to really, move, they've had that immobility of the joint for a while. When they take that cast off or get out of that cast, oftentimes they will go to physical therapy. And at physical therapy, one of the first things they'll do is test their range of motion that they're starting out with. And the overall goal is to increase their range of motion as they are there, because they've had this disuse from the joint being immobilized, and now we need to get the range of motion back to normal. Now, as we age, our joints will experience the decreased production of the synovial fluid. We'll also have a thinning of that articular cartilage, because remember, as we age, we begin to lose our protein production, or our protein production begins to decrease. And so we get the thinning of the articular cartilage, so we don't have that protection and that absorption where the joints are. We also begin to lose the length of the ligament and its flexibility. And so this is oftentimes why we see those issues of wear and tear that we consider on our bodies as we age. So some of it can be genetic, but a lot of it is simply because of these factors here that are just attributed to wear and tear. And so arthroplasty is a joint replacement surgery that can be performed to counteract some of the effects of aging. And so in this arthroplasty, they will actually go into and repair the joint. So here is an example of an arthroplasty for a hip replacement. And this replacement, it will involve both the acetabulum and the head of the femur. And so what will happen here, is they will have to reshape the acetabulum, or the place that our femur will fit into in the hip. They'll reshape that acetabulum, and then they'll actually remove the actual head of the femur. When they remove the head of the femur, they then take this artificial hip joint. It has its nice artificial acetabulum and femoral head, and then it has a metal shaft. And so this metal shaft will be inserted down into the femur, and then the acetabulum will be aligned with the hip bone. And as you can see, there is a small pin inserted here to hold it into the hip bone. We also have knee replacements that we do for arthroplasty. This knee replacement will involve resurfacing the cartilage in the knee, and we can either do a partial or total knee replacement. So here are the artificial knee component joints, parts of the knee component joints, the femoral component, your tibial component, and then of course the patellar component. And so here you see the radiograph of the total knee replacement post arthroplasty. Now we have a few disorders that we'll see at the joint level. So of course some common injuries to our joints include rotator cuff injuries, a separated shoulder, tennis elbow, and then dislocation of the radial head and the knee joint. So those are fairly common things where oftentimes the joint has just been displaced, and we need to get it back into its alignment, or some things that are causing some strain and some inflammation of the joints. Now, the other disorders include rheumatism and arthritis, and rheumatism will be any painful state of the supporting structures of our body. So that can be bones, that can be ligaments, joints, tendons, or muscles. And in rheumatoid arthritis, we have an autoimmune disease, meaning that the body's immune system is actually attacking itself, and it's attacking its own cartilage and joint linings. And so, because we're attacking the cartilage and the linings of the joint, it results in a loss of joint function, causing the pain and the arthritis seen there. Now, arthritis itself is just simply a form of rheumatism, so meaning that painful state of any of our supporting structures. And in this, it is painful because the joints have become inflamed. And so we have two types of arthritis we'll talk about here: osteoarthritis and gouty arthritis. So osteoarthritis is the degenerative type of disease. And so degenerative meaning it will happen over time as things lose their function. So it is known as a wear and tear arthritis. It's characterized by the deterioration of articular cartilage and bone spur formation. It is non-inflammatory and primarily affects our weight-bearing joints. Now, gouty arthritis, on the other hand, if you've ever heard someone say they got the gout, it's a condition in which sodium urate crystals become deposited in the soft tissues of the joints. When these salt crystal deposits become deposited in the joints, it causes inflammation, swelling, and pain. If it's not treated, the bones at the affected joints will eventually fuse together, and so those joints will become immobile. Lyme disease will be caused by a bacterium that's transmitted by deer ticks. Lyme disease will be more prevalent in the northeast U.S., and its symptoms will include joint stiffness, fever, chills, headache, and some low back pain, because it also will affect your kidneys. And then we have our sprains and our strains. A sprain will be a forcible wrenching or twisting of the joint that occurs, whereas a strain is going to be with your muscles or your tendons, where the muscles or tendons are partially torn. And then tenosynovitis is any inflammation of the tendons, the sheaths, or the synovial membrane. And finally, the last disorder we'll discuss will be this dislocated mandible. So any displacement of the bone from a joint with the tearing of the ligaments, tendons, and the articular capsules. So please be sure that with this chapter 9, you know the types of joints that we have, functional and structural. You also are able to go through the types of synovial movement at the joints, and you are also able to describe the types of synovial joints, how we types of fractures, and the repair of fractures, as well as the disorders and imbalances.